What are the risk factors for developing macrovascular complications in the setting of diabetes, which magnifies these things, but all over, I mean, as an umbrella question?
So I'm a lipidologist, and I think...
So let me guess, your first answer is lipids.
So obviously, there's a multitude of risk factors that are important, but if you look in a stepwise fashion, the dyslipidemia is probably one of the most important, because as a risk factor, there are a lot of different risk factors, but you can develop atherosclerosis even if you have normal blood pressure, even if you're not obese, even if you don't smoke. But unless you have an abnormal lipid particle that can get into the artery wall and start atherosclerosis, you're not going to get it.
So if I were to follow that to its logical conclusion, I'll take a statin, I'll take my LDL way down, or I'll take some of these newer drugs and drop my LDL to 20. Am I safe being a diabetic?
No, patients with diabetes are still at risk because there are other risk factors.
Okay, what are the other risk factors?
Hypertension, obesity, insulin resistance, as we mentioned, dysglycemias.
Okay, but is there something that's more important? You're a lipidologist. Does that mean that lipids first, everything else second, or?
So again, I agree with what you say, but I rejected it a bit. I'm not going to prioritize.
Don't reject me.
Not you.
He's all alone at
But
the
you're
end
saying
over there.
we have to go in a stepwise fashion, and I say no. If you have a newly diagnosed patient with diabetes, I'm going to say, let's have a nice discussion about what your various risk factors are, and I'd like you to start your statin. I want to get your blood pressure down, and I'd like you to start a glucose control agent.
So Carol, I don't disagree with that. I think the problem is that we tend to overwhelm the patients, and as you know, most patients will stop their therapy within 3 months because they're overwhelmed. So I think I would rather work with the patient, the whole patient, and find out what they're willing to do and give them some successes, some wins. So I think in our effort to overwhelm the patient by getting all their risk factors under control, we do overwhelm them, and it's hard to do it. So I think some patients will really go with that, but I try to work out what is the patient's understanding and work with that and do it on a gradient basis. The other thing I want to just, as a lipidologist, I think part of the problem is that we've become, quote, LDL focused, and we aren't really measuring sort of subfractions of LDL. So
why would we?
well, that's an interesting question, because the thing is that, well, the LDL's normal. You know, and people don't, you know, and you have a lot of patients with, quote, normal LDL. Is that giving us enough information?
So I was one of the authors of the 2013 ACC/AHA cholesterol guidelines, and we stopped focusing only on the LDL.
Right.
We focus on the risk. So I actually, honestly, if your LDL is 40, I kind of don't care, because if your risk is high, I'm going to treat that.
So you'll treat an LDL of 40 with what?
A statin.
Really?
So it depends on the context.
If the risk is high, yes.
So if you're in a high-risk group and that LDL is 40, you can do better, that will lower your risk. Is that what you're saying?
Right. No matter what it is, it's too high for them.
Okay.
And we know even with patients who have established cardiovascular disease, if you do reduce their LDL even further, patients do tend to do better. And so I don't think there's a threshold where we say there's a patient that we're worried about for cardiovascular disease. We need to be aggressive in those patients regardless of what their number is for LDL.
In the early days of the statins, what I recall, I think it was Nissen, pointed out that at least in his studies, there was no threshold below which you could not further lower risk.
And that's exactly right. We've not seen the floor of LDL lowering with statins. I assume there is one, because there is with everything, but we haven't found it yet.
Now, I guess this is then the key question. If we're looking at diabetics as a group, and we're looking at their cardiovascular risk, are we as a profession, physicians, doing enough to really address this risk, all comers? And are we entering an era where we really need to re-examine what we're doing and how we're approaching it?
I believe so. I mean, if you look at recent data, in 2010 at least, 81.1% of individuals with type 2 diabetes were not hitting the ABCs in terms of A1C, blood pressure, and lipid.
Not hitting all these critical
markers. The three markers, and they have residual risk, even in the best, under best circumstances. So I do think we can and should do more.
What about the medications we've got? Should we be asking more from the medications we've been using traditionally to treat diabetes?
Yeah, and I think, you know, as Stephen had mentioned, the focus, I think, on diabetes management had really been around glycemic targets. And not that that's not important, but we realize, especially when we're talking about cardiovascular disease and macrovascular disease, that there's a relationship that is certainly on hyperglycemia, and that's also important, but we know most of the events that occur in diabetics actually occur at reasonable hemoglobin A1C. The majority of first-time MIs actually, if you look at a population level, actually occur in patients who have hemoglobin A1C around 7. So clearly there's something happening, and Karol mentioned this, in the process of insulin resistance and diabetes that's happening for decades, and they're having an atherosclerotic burden that's progressing over many, many years before they even get diagnosed with diabetes and well before they have their first heart attack or stroke.
So we
now
should be asking of our medications, don't just control my sugar, but somehow or other, please help me with my cardiovascular
especially
risk.
now that we're having emerging medicines that these diabetic medications also may have beneficial cardiovascular effects.